right. Well, it's about time. Welcome to the AO North America hand webinar series. Today we're going to be speaking about distal radius malunions. And I am very, very blessed to have two excellent hand surgeons, academic hand surgeons on today as our faculty. And I think that they have a tremendous experience in treating just wrist fractures in general, and also malunions, which goes with taking care of distal radius fractures in the whole scope of wrist fractures. And so Dr. Gill, Joseph Gill, is from Brown University, and Dr. Andrew Miller's from Thomas Jefferson University in Philadelphia. And I'm Peter Reet, your moderator. Here are disclosures. And then you do get CME credit, which is a huge bonus. There'll be instructions at the end on how to get CME credit. And this is just a content validation statement. You could take a look at this. Okay, and here are learning objectives, really just pertaining to how you evaluate, plan corrective osteotomies of distal radius malunions, and then just some kind of techniques, tips, pearls, tricks on how to manage these, which can be quite challenging. And here's our agenda. I'll just briefly go over just general principles of how to approach distal radius malunions, both intra and extra-articular, and then our faculty will take over one portion extra-articular versus intra-articular, and then I think the one of the greatest parts of these webinars are the case discussions. Okay, so then I'll just give a kind of brief overview of my thoughts on distal radius malunions and how I approach them. It's interesting because people have talked about nascent malunions, established malunions, and I always wonder where that came from. But of course, it came from Dr. Jupiter back in 1994. And the earliest kind of recording of or documentation of what a nascent malunion was from this OTA meeting, and it was just an abstract. And he's just brilliant, Dr. Jupiter. And he just noted the fact that, a nascent malunion where there's still fracture planes, it's a little bit different than treating an established malunion where everything is healed. And I think the main thing is the fracture planes that may still be present that you can utilize where there's still immature bone that you can help to use as a guide in these inherent weak areas to perform your osteotomies. And established malunions, those you kind of just start from scratch. And that goes to really the principles. When I look at a intra-articular malunion, sometimes I get a little overwhelmed. But then I think back to what would I have done when this patient first came in with these acute fracture fragments. And then I realized all I really need to do is create the same fractures, mobilize them fully, and then I just start as if I'm starting from the beginning, using a volar locking plate, which I think is great, especially if there's metaphyseal comminution or definitely like a bone gap, area of bone defect when you do your opening wedge osteotomy, if you choose to do that. And then from there, just having a lot of different ways to elevate your complexity of your implants that you want to use to stabilize these fresh fractures that you've created. And I think to do that, you really have to have a good understanding of these fracture fragments, whether they're an acute fracture or you've created them. But these are osteoligamentous fractures, which I'll go into here in a little bit. And then you really need to be comfortable really going volar, radial, dorsal, ulnar even, and then just having a lot of different tools that you can use to stabilize these fracture fragments. So I alluded to the fact that there are these osteoligamentous fragments, and I really like to use this column concept described by Rickley and Regazzoni, and it really just goes to say that within this intermediate or central column, there are a lot of fracture fragments that can occur. Now, there can be a lot of different variations, but the kind of actually astutely noted by Malone in his classification, these are fairly predictable fracture fragments. And so if you have a nascent or established intra-articular malunion, I just try to think back of, and you could kind of glean that from your imaging studies, but I just try to see, what the fragments could have been and how I can reproduce them. And it helps me realize then how would I have fixed that with what type of fixation methods based on how big the bone is. So these are some of the fragments that can occur, with the radial column being its own kind of separate piece. But in this example, actually, the radial column piece is kind of comminuted. But they're predictable because these fracture planes occur in these little weak areas between the origins of radiocarpal ligaments, and where those ligaments attach to the bone are just inherently stronger from the stresses that are there. And so these fracture planes can go through these like little weak areas, and that's why they're fairly predictable. So then if you have these fracture fragments, then you can kind of trace out to exactly what ligaments attach to them. Like in this fracture here that I created in this cadaver, you can see there's a volar rim piece, radial column piece, and then with that volar rim piece, there's a short radial lunate. Radial column piece, there's a radius capitate, long radial lunate. And then same goes on the dorsal side. Really, there's just dorsal capsule and the dorsal radial carpal or the dorsal radial triquetral ligament. But that also has some implications, because if you try to create these fresh fractures and then you try to use just ligament ataxis, realizing that some of these ligaments don't even attach to these pieces. Like here in the dorsal ulnar corner, the DRC or the dorsal radial triquetral ligament may not even have a footprint on it. And so when you try to pull this out, it actually doesn't even pull. And so you have to use whether you're using small mini incisions or using intrafocal type reduction techniques, you have to actually use that as opposed to just pulling on it or pressing on these fracture fragments. And then so if you can figure out these intermediate column fracture fragments, whatever they are, and then you can recreate the fractures, then it's just starting like your puzzle from scratch. Start your puzzle from the outside or wherever what's most predictable. But here, starting with the volar rim piece and wrapping around the dorsal ulnar side, and then finally just buttressing that radial column. And then if there's any ulnar-sided pathology, whether soft tissue or bone, you treat that next. And so I think that if we look back at just acute fracture sequence of reconstruction, again, I think this is a fairly reproducible, consistent way that you can fix these. And if you have all these fracture fragments, then this is kind of how I have my building block with this critical corner in the volar rim attached to stabilized to the metaphysis, and then I can work my way around. So this is a nice little animation that we created that kind of just shows that illustration again. But I'm just going to skip to here. And then it's from there deciding what's the best implant to use. And it can be one of these, combination of these, can be pins, buried, or subcutaneous. It's just whatever you need to get that fracture fragment that you've created now mobile, this malunited piece, if it's intra-articular, and just getting it into the right spot and stabilizing it. And then lastly, I just wanted to say that if you then, when you think about the acute fracture that may have happened, understanding the different mechanism of how that fracture occurs can also help you think about things that you may want to have a higher index of suspicion for an associated injury. So for example, when you have this dorsal bending type mechanism where someone's typically low energy, fallen outstretched hand, we know that these are apex volar injuries, but a lot of times you can have these small dorsal rim fragments, or like in this example, so it's a patient who broke their wrist during COVID, and everything was shut down. So we kind of had to painfully watch this fracture being treated non-operatively. And then you can just see that, knowing that's a dorsal bending mechanism, that there may be an associated dorsal rim fragment. Advanced imaging really helps you decide, is it truly extra-articular? And knowing that this is dorsal bending, maybe you have a dorsal rim fragment, maybe you have a dorsal ulnar corner fragment like in this patient. Knowing then that, once it's all healed, that there may be some malunited areas here that you may have to address. And I think knowing if it's nascent or established or not helps you decide, do you have to completely find a new plane to create an osteotomy, or can you try to use um, a somewhat not mature plane to recreate your fracture? And then certainly you can look at your sigmoid notch, because certainly you don't want to just get the alignment right and get the radiocarpal joint corrected, but and disregard the sigmoid notch in the DRUJ. Or there's a different animal, which is more of an axial loading injury. And what this tells you then is instead of that typical dorsal bending mechanism, this is kind of where the on a lateral in the sagittal plane, this lunate, the scaphoid just kind of pile drives into this distal articular surface of the radius, and it can actually, you can actually see here the distal articular surface of the radius to lunate ratio should be 1 to 1. That's much greater because now it's split open. So now if you're going to treat this, you may not just be able to do a extra-articular osteotomy just to get that into more volar tilt. You may have to actually address an actual split in the coronal plane that now is causing a mismatch in contours of your proximal carpal road to your distal radius articular surface. And certainly here you can see that is the case. Not saying you always have to create an intra-articular osteotomy in something like this, but it's just good awareness and a higher spidey sense, if you will, mainly because you can go back to say this is probably the mechanism of this injury. And here's this patient here after 3 months of not having that treated. Okay, so then just to wrap up, I always think about, any bony reconstruction, but certainly for corrective osteotomies of distal radius, what are my goals? Articular congruity, for sure. Dr. Jupiter showed in his study, albeit he even admits there's some flaws to it, but showing that if in young patients you don't get the articular surface just right, that will lead to post-traumatic arthritis, at least radiographically. So getting both the radiocarpal distal ulnar joint articular congruity just right, and then achieving your goal of correcting your radial height, tilt, inclination, and then really importantly, getting your carpus aligned to radial shaft, because we know that if it's not aligned in the sagittal plane, that can lead to some adaptive carpal instability patterns. So I always think about these things as I'm operating and planning on corrective osteotomies of distal radius malunions. So my take-home point before we get to our speakers is that, you really have to understand the mechanism, what the fracture fragments could have looked like. Sometimes it's hard when everything is healed and you don't have these clear fracture planes anymore. But then once you do, it's just creating these fractures again, and then mobilizing them enough. I can't stress that enough. You got to mobilize these fracture fragments because there's a lot of periosteum callus that can limit your reduction and just provide stable fixation. So in summary, I think these malunions don't always fit the same cookbook recipe. I think as long as you understand the osteoligamentous anatomy, you're comfortable working 360 around the wrist. You can reproduce these fracture fragments with osteotomies, and then just really having a lot of different tools to just stabilize these fracture fragments, keeping in alignment with those principles. And I think if you just keep that in mind, I think you're going to be in good shape. Okay, so that was just the introduction to kind of how I approach things. Now we'll have Dr. Gill. Joe will go through kind of his approach and the reason, or I guess how he evaluates and treats extra-articular distal radius fracture malunions. All right, Joe, all you, buddy.
All right. Well, Peter, thank you so much for inviting me to be part of this panel. Today I'll be focusing on the extra-articular malunions. And like Dr. Reese said, I'm from Brown. Take a lot of wrist fractures, and some of the extra-articular ones are the ones that I think are a bit more rare if you follow those closely. Those are the ones that are typically referred to us from either a pediatric fracture that was managed with pinning that ended up having a physeal arrest, or somebody that just was lost to follow-up or never made follow-up and showed up late. So in your own practice, if you follow these, you hopefully won't encounter them in your own patients too often. So just an overview. I'll do a brief.
Hey, Joe. Oh, Joe, sorry. Go to slideshow because I'm seeing your.
Sorry about that. I pressed
Yeah,
it.
it's okay.
Sorry about that. All right.
Perfect.
You got it. Perfect. All right. So overview of the topic. So we'll do the introduction, radiographic assessment of these, and kind of what defines malunion based on defined radiographic parameters, a brief classification, talk about how patients present with these things and kind of what symptoms they complain about, talk about operative and non-operative management, operative considerations, including soft tissue releases that should be performed to achieve your goals. And finally, we'll end off with some complications and a brief case before we jump to Dr. Miller's topic. So distal radius fractures, as we all know, are one of the most common adult fractures, accounting for 16% of all adult fractures. Malunion is defined as deformity that exceeds defined parameters and are associated with suboptimal outcomes. And again, not in all cases, but these are the ones that are typically that interest us if they show up and they're complaining about the fracture, the way it healed, and how they're feeling. The malunions result in altered relative position of the radius and ulna, impacting loading, which results in issues with range of motion and symptoms, and also impact carpal alignment. And then malunions are known to be associated with patient-reported outcome issues, including proven studies that showed problems with SF36, grip strength, and dash. So malunions can be defined by this list. This is just some of the parameters that are published and known. How we assess fractures. On the right, you see the normal volar tilt 11 degrees, the radial inclination of 23 degrees, radial height of about 1 centimeter, and then typically ulnar positive variance. Critical, I think, in kind of that component of it. Not everybody has ulnar neutral or positive variance. Could have a congenital or born with ulnar positive. So it's critical to assess the contralateral side when using ulnar variance as part of your assessment. Malunion would be defined as dorsal tilt that exceeds 10 degrees, volar tilt that exceeds 15 or 20 degrees, radial inclination that is reduced under 1 centimeter or 10 millimeters. I apologize. That's radial inclination is less than 10 degrees of radial inclination, and the radial height is 3 millimeter loss of radial height. Again, issue with ulnar variance compared to contralateral side. Radial translation of the distal segment of the radius relative to the shaft on the AP or the coronal plane. And then radial carpal or mid-carpal malalignment secondary to the carpal adaptive instability. So more specifically on dorsal angulation, when it exceeds 10 degrees, the clinical presentation typically presents with ulnar wrist pain or decreased forearm rotation. Issues with distal radius translation of the distal segment in the coronal plane results in laxity of the distal radial ulnar joint and associated instability and symptoms at the ulnar wrist. And the carpal instability, the non-dissociative instability that we briefly alluded to earlier, the two types as determined by the effective radial lunate flexion angle. If it's less than 10 degrees of dorsal tilt, you have the type 1 effective radial lunate flexion angle where you have radial carpal neutral alignment and the flexion occurs through the mid-carpal joint. And when that exceeds 25 degrees, and these tend to be the more symptomatic ones, the radial carpal joint has the flexion deformity and the mid-carpal joint is neutral. So simple classification of these. They're dorsal, volar, or neutral. The dorsal ones specifically look at the radial lunate flexion angle, like we just briefly discussed, whether it's less than 25 degrees resulting in DZ deformity, and the greater than 25 degrees results in more of the radiocarpal flexion, and the mid-carpal joint goes back to neutral, but these tend to be more symptomatic than the ones with the DZ and type 1. These can be associated with a loss of radial height or inclination and could be associated with ulnar positive variance typically. The volar ones typically have ulnar positive variance and again are associated with loss of radial height or inclination. And the neutral ones specifically, this is the ones you'd see on the coronal plane where you'd see loss of the radial height or the loss of radial inclination. So patients will, as briefly mentioned earlier, will show up with loss of range of motion, pain, either at the ulnar wrist or globally, reduced grip strength, and patients will often complain of radial nerve symptoms due to alteration of the anatomy of the carpal tunnel. As far as management of these, a lot of them that you choose to non-op because of their functional demand or of their ability to kind of use their wrist in general. If they end up with a malunion, those I think aren't as clinically relevant. If you chose to kind of decide, if you decided with the patient that's the best thing for them based on their functional status. So those we tend to we know they're malunion and accept it, and those we manage non-operatively. And those I think in my practice, the ones that I tend to indicate for non-operative management that end up healing with a malunion, they tend to do just fine, and I don't chase the radiographic parameters. The ones that are indicated for surgery specifically are where the functional impairment is specifically related to malalignment. So it's not something about their, like a carpal ligament injury or arthritis, but it's specifically the loss of that radiographic parameter that's resulting in their loss of range of motion or grip strength issue that would motivate me to assess that malunion and correct it in that patient. And contraindications to malunion correction would be advanced arthritis and things that, again, where the problem is not necessarily attributed to the malunion itself. So for preoperative planning, for extra-articular malunions, I think, it's critical to have the contralateral film, particularly for when we use ulnar variance as a radiographic parameter that helps guide us. If a patient's already ulnar positive, you're not chasing that with their malunion correction. You focus on the things that, again, matter based on their anatomy. And in my practice, if it's an extra-articular malunion, I'm pretty confident based on where the fracture is. I don't necessarily get a CT scan. I think with some of the technology available for 3D printed jigs and stuff that's not necessarily proven to improve outcomes, but if you head that direction, CT scans are useful to kind of create those jigs. Timing, as Dr. Ree mentioned, the ones that are more nascent tend to do better, whether that's because they have less soft tissue contracture or they have existing fracture planes that you could replicate. They tend to just have been proven to be better outcomes in those patients, whereas the ones that are more established, I think, where you have to do like a new osteotomy at a point that you're just kind of basing on your assessment, those tend to do a little bit worse. And I think whether it's to do soft tissue contractures or just because the patient's been doing poorly so long, it's hard to make them better. The goal of malunion correction is to restore the radiographic alignment. I mean, that's the concept here in malunion correction. As Dr. Ree discussed, there's a lot of ways of doing this. Specifically for the osteotomy, it could be an opening or closing wedge osteotomy. For the opening wedge osteotomies, it could be either hinged or complete. I think that's based on how much height is lost, how much length is lost, and how ulnar positive that wrist is. If you're trying to correct not only the radius, but also trying to realign the variance, I think, you're sometimes obligated to do a complete osteotomy and then fix that in whatever way you determine is the best suitable for that patient, whether it's a volar plating combined with dorsal bridge plating or fragment specific fixation. And this, whether or not you bone graft, I think it's, there's studies out there that clearly demonstrate that you don't need to bone graft. But if I do a complete osteotomy, I think filling that defect with either iliac crest bone graft or proximal tibial bone graft, it just makes me feel better. That's going to heal to reduce that complication risk of delayed union or non-union. If you leave it hinged, I think those tend to heal without needing bone grafting. And the closing wedge osteotomy is nice because you'll get your compression across that correction. However, you will definitely result, or in a lot of situations, have that ulnar positive problem afterwards where you have to do either an ulnar shortening osteotomy or SK or something to address the ulnar risk because you're going to, a lot of times, exacerbate that problem. This is an interesting preoperative planning concept I came across. I think this will help narrow down whether you should be considering closing wedge or opening wedge osteotomy. That's the concept here. It's called the center of rotation and angulation. So this is just an example of an extra-articular malunion in this figure. So A is less severe, the B is more severe. So the way this is done is if you look here in A, dorsals to the left, volars to the right. So you first draw a line from the dorsal, and this is templated based off of the contralateral wrist X-ray. So here in A, you're going to see the normal contralateral wrist. That's you could see at the correct position, and then the malunions overlapping it. So for the dorsal cortex, they draw a line from the tip of the non-fractured side to the fractured side, or the malunion side, and then they draw another line from the volar cortex of the malunion to the normal side. And what they do is drop a line that's perpendicular to the midpoint of each of those lines, and as they cross, that's your center of rotation and angulation point. If that point intersects the bone of the of the normal side, then typically you could get away with doing closing wedge or an opening wedge osteotomy to make the correction, as you could see here in A. Whereas in B, where it's a more severe malunion, in that center of rotation and angulation ends up outside of the bone on this templating, then you could see that would relieve you would need to do a complete opening wedge osteotomy in the situation. So it kind of gives you a sense of when you could get away with just doing an opening hinged and closed versus a complete osteotomy. Soft tissue issues that you should consider, particularly on the ones that are more established malunions versus the nascent ones, are a brachioradialis release to achieve length. And then for once you achieve your fixation and you feel like the forearm rotation is extremely tight at the DRJ, you could do a volar or dorsal or both dorsal DRJ capsular release to facilitate that range of motion for the rotation of the forearm. So these surgeries, particularly in the more established malunions, they come with significant complication rates reported, up to 50%, including acute or delayed tendon injuries. The acute injuries would be if you drive your osteotome across the tendons, for example, or the delayed ones would be if you fix a malunion with the volar plate and your screws end up being too long and you could get an EPL rupture and extensor tendon rupture. If you don't bone graft, you could get a delayed union or non-union, and it's been shown to there's significant rate of median nerve neuropathy when restoring length in malunion. So it's important to make sure the patient also gets a carpal tunnel release during that surgery. So this is just a single case example. I know we'll get to cases later, so just quickly reviewing the concept of an extra-articular malunion. This was a 9-year-old kid. When he was 9 years old, he had a bike accident at an outside hospital. He was close reduced and pinned twice, and he lost reduction and ended up ultimately getting a physeal arrest. And he presented when he was 16 years old to us. So here you clearly see the loss of the radial inclination, and on the lateral film you see this is dorsally angulated, the fracture malunion itself here. So the complaints, his primary complaints were limited rotation and dorsal and ulnar wrist pain. So we offered him a malunion correction. So our two goals were to restore his radial inclination and to correct his volar tilt. So we did an extra-articular opening wedge osteotomy that we left hinged. This is just his contralateral side showing that normally he would be slightly ulnar negative here. And again, you see his normal inclination and tilt. So again, critical this is kind of our goal with our malunion correction. So that's what we based it on. So here you see we did a opening wedge hinged osteotomy, fixed it with the volar plate, and 3 months later, he went on to heal with full range of motion, no wrist pain. So this is the main study I referenced for this for this discussion. Dr. Lauder from University of Colorado, I did discuss that center of rotation and angulation with him and how he used it in his practice, so that he was very helpful in putting together his talk. Thank you.
Dr. Gill, thank you. I think that was a really good review of the reason why these are so important to catch early. And then also, once you do identify these extra-articular malunions, a good approach to planning your osteotomy and your surgical plan. And the center of rotation angle, I admittedly have not used that very much, but I think that it's an even more elegant way to plan ahead of time so you know what your limits of correction are. So that was fantastic. Thank you. All right, next we're going to go to Dr. Andrew Miller. He's going to talk to us about how he evaluates and approaches intra-articular malunions.
Great.
Go for
Thanks,
it, Andrew.
Peter. Thanks, Peter. And thanks, Joe, for that talk. Let's see if I can share this with you guys. Everyone see that all right? Joe,
Looking
Peter, that looks
good.
good to you
Yeah, we
guys?
see it.
Perfect.
Looks good.
Great. Thanks, guys. Well, thanks for joining in. We're going to talk here for the next 10 or so minutes on intra-articular distal radius malunions. Nothing to disclose here. So really, we'll review a few things, some principles and parameters of distal radius fracture malunions as it relates to the intra-articular component, some surgical approaches, and then some treatment and outcomes. So what matters most for patient outcomes for wrist fractures? Joe, I know, touched on a few of these. And when we were putting together a chapter for this edition by Jesse Jupiter on patient-reported outcomes and what matters, really the three big things that came up were radial height, or as it relates to your ulnar variance, the intra-articular congruency and step off, which was approximately 2 millimeters. That gets quoted a lot, and then the radial translation as well, because that impacts your DRUJ. So, and Peter mentioned this, Jupiter paper really goes back to the 80s when he put this out there regarding intra-articular fractures of the distal end of the radius, and how there was a significant amount of post-traumatic arthritis several years after these injuries. Now, he did retract a little bit, at least, or he criticized some of the methodologies of his original paper, but the outcomes and the conclusions were still the same. His one comment was, if really the treatment and the goals of the osteotomies and the management of these malunions doesn't really matter, isn't going to improve it too much, you have to be careful with what you're treating and what your indications for treating these are. So just a note about step off. I think we use this word a lot when it comes to intra-articular malunions and what the articular step off is. In my mind, when I think of step off, I think of it in two ways. Is it a step down or is it a step up? When I think of step down or the kind of usual step off, and these come in different varieties. And I like to think of it like a pothole in the ground. So when you're driving your car over a pothole, if it's small enough, you won't really notice it. If it gets really large and widespread, then you're going to feel that bump in the road, and that's what's going to create that edge loading and the articular injury and wear and tear on the cartilage. Your step up is going to be sort of the elevated joint lines, which probably are a little bit more rare, but can cause significant local and regional chondral wear. Or if you have loose bodies, osteochondral fragments from your fracture, these can be serious issues. There are definitely a lot of patterns of articular incongruity with distal radius intra-articular malunions. Dr. Ree made a comment on the osteoligamentous anatomy, and that certainly is true, and that kind of determines where a lot of these fracture lines and therefore malunion lines will ultimately be. But I also want to mention too that, when we talk about the sigmoid notch and some of these extra-articular malunions that we typically think of, extra-articular fracture, and now it's an extra-articular malunion. Well, technically your sigmoid notch is really an articular surface, and I would treat it as such. So a lot of these are important when you're thinking about correcting these traditional extra-articular malunions. They're actually intra-articular malunions as well. You also have your lunate facet, your volar rim fractures that can go on to lead to DRUJ instability and carpal subluxation, your dorsal ulnar corner, your radial styloid, and your central die punch that Dr. Jupiter initially mentioned back in the 80s. So surgical management of these comes in a lot of shapes and forms. In addition to non-operative management, which I agree with Dr. Gill, I think you have to have a good conversation about these. The ones, at least in my hands, that I consider for surgical treatment are denervations and scope debridements, intra-articular osteotomies, and then partial versus total fusions. So first, with wrist denervations, I think this is certainly a tried and true treatment, and I like using this a lot in my own clinic for a lot of post-traumatic arthritis. Particularly when there's fairly a good amount of arthrosis that's set in. Now, this can be combined with arthroscopic debridement and synovectomies, and even resection arthroplasties that Dr. Penal over in Spain has popularized, where he's trying to preserve that secondary congruence, but he's trying to really contour and smooth out some of those articular step-offs in order to better allow for that radiocarpal articulation without that impaction, without that impingement and that advanced wear and tear. When it comes to osteotomies for intra-articular malunions, I don't think there's really any true and definitive indications. I think a lot of these are relative indications, I said, because I think you have to have a real serious conversation about what your goals of treatment are. In my mind, and this is, I think, true with Dr. Jupiter and Dr. Ring, who's published on this as well as several others, right? Young and active certainly comes to mind. You really can't have a lot of arthritis, really minimal arthrosis. If you have pretty significant arthritic wear and tear, I don't think you're going to accomplish much. Really, you need to have good CT and 3D reconstruction. I think I agree with Dr. Gill on the extra-articular side. You may not need it as much. For the articular side, you really do need it. Contralateral films are nice to have as well. I think if you have, again, greater than 2 millimeters of step off, kind of quoting that metric that Dr. Jupiter brought up, that's also a relative indication. If you have volar and dorsal subluxation of your carpus, or if you have DRUJ impairment because of your articular incongruity, those are also, in my mind, relative indications. I'll mention this hand clinic article that came out recently about management of intra-articular distal radius fractures, and I'll highlight kind of their key points, which are that normal wrist function should not be expected, and long-term post-traumatic arthritis is to be expected no matter what you do. Now, I'm not a huge fan of a lot of the 3D modeling that is utilized. Again, there's no study that's demonstrated superior outcomes with 3D modeling, but I think you still need to have good 3D reconstruction. So, reformatting your CTs, getting good three-dimensional understanding of the malunion is important and paramount to success. This is that textbook that Jupiter release that a few of us contributed to. With the intra-articular malunions, I think it's also important noting that even despite having some good relative indications, there's still mediocre evidence that a lot of the symptoms can be significantly improved by intra-articular malunion correction. And I think you also have to realize that a lot of these intra-articular malunions are, in fact, related and in combination with extra-articular malunions, and you have to correct not just the intra-articular, but the extra-articular malunion when it exists. So approaches really depend on the type of intra-articular malunion. And again, this is why I think you need to have a good 3D reconstruction to figure out and template your plan of attack. So sigmoid notch, typically for me, that's volar, especially if there's a lot of radial translation from an extra-articular injury that has to be corrected. Your volar ulnar corner, I'm typically using an extended FCR approach, although I would consider a volar ulnar approach between the flexor tendons, the ulnar neurovascular bundle, if it's purely isolated to that volar rim. Dorsal ulnar corner and wall, typically considering that fifth dorsal compartment, plus or minus an arthrotomy, depending on how significant it is. Radial stylet, I typically use a radial approach and a first compartment approach. If you have that central die punch, that typically is a dorsal with an arthrotomy for me. And then oftentimes, again, these are combination. And so I wouldn't hesitate to consider both volar and dorsal approaches to these. And then a few points to when you're doing these approaches and you're kind of figuring out how to attack these. Consider performing a corticotomy. So, sometimes it's really hard to get an angle of attack if you're using osteotomes, for example, and creating back cuts into the bone allows you to get better angulation with your instrumentation. So, something that I've learned can be very helpful. And then you can do volar arthrotomies as well. It's not commonly as done, but you can certainly, especially for those volar radial and volar lunate, you can actually assess the articular surface from that side. And I don't think it's as morbid as a lot of people would make it out to be. When it comes to instruments for these, in addition to that pre-op CT, things I'm asking for and I'm having available: K-wires, osteotomes, both curved and straight, fragment-specific plating, bridge plates. Your bridge plate can be both a definitive treatment, but it also can be used kind of as a jack. If you're changing a flat tire, you want to be able to distract, you want to be able to offload and really assess the fragments and offload any correction you do. I do like lamina spreaders, small ones. Again, also another type of sort of like a jack to distract the fracture or the joint. Bone graft, because oftentimes I'm backfilling if there's bad impaction that's settled. Those cancellous chips can help to restore that bony anatomy. And then arthroscopy equipment, I also like to have available as well. Plating specific fixation, central impaction with osteotomies, I'm also looking to use a bridge plate for that. Again, if I'm doing more of like a radial osteotomy, a radial plate is nice to have because it gives me a nice line of attack for that. And then that lunate facet, I'm considering more fragment-specific fixation for that volar rim piece. The arthroscopic approach, is an interesting technique, and I think, one, you should recognize that this is not a surgical center, with you and a scrub tech. You really need about 2 or 3 skilled pair of hands to do this. And I visited Paco Penal and, saw him work, and, he's a technical genius, but he has, 2 or 3, fellowship trained surgeons working with him to get this done. But it's an important thing, and certainly you can have it in your armamentarium, and it really gives you real-time planning and correction capabilities. It's an inside-out approach. You can use specialized instruments. He likes to use a lot of these shoulder osteotomes for labor repairs. And it can really help you assess these complex irregular fragments. If there's localized cartilage erosion, I know Dr. Penal likes to use a lot of vascularized osteochondral grafts, but again, very technical and really kind of beyond the scope of this talk here. So, for example, here's a case that I had a second opinion on, a young lady that worked in the ER. An articular fracture, treated non-op in a cast for about 2 weeks and a brace, but got progressively worse, painful, and came to see me for further evaluation. And over time, she started to have some of this carpal subluxation. She had a little bit of arthrosis forming, and you can appreciate sort of that loss of that radial height relative to the ulna. And so after discussing all the options, and given the fact that she was young, given the fact that her DRUJ was really impaired, that was sort of the key part of it, we decided to go forward with an intra-articular osteotomy. And I had CT planning, and you can see where sort of that carpus is starting to sublux volarly. You can see where some of that those fracture lines and some of that step off is, and you can see even some of that fracture scar and that axial cut. So it was somewhat regular, but I thought it would be something I'd be able to get to. And so I made this volar corticotomy, and I decided to go all volar for this because when I tried to use the arthroscopic approach, it was just so much fibrosis. I couldn't even visualize a whole lot. So I did go totally open here and made a volar corticotomy to allow my osteotomes to get a better angle of attack. And then I was able to break through and then re-elevate that joint line and use a volar plate to hold it together. And she had excellent restoration of that. Pronation and supination, still limited on the wrist flexion extension as before, but her rotation was significantly improved, which was really the goal of the surgery. Salvage procedures, I think you always have to have this in mind because, again, a lot of these may not be amenable to osteotomy and fixation. And there are motion preserving versus motion eliminating if you're going to go the total fusion route with different complication risk. And I don't know if this is still a mantra or not, but I remember this when I was in fellowship. Dr. Shin used to say motion is pain and fusion is life. So sometimes maybe just a total fusion is the most definitive approach to dealing with this. The type of partial fusion you're going to consider is a radioscapholunate fusion. There are traditionally high rates of non-union with these, but that was really when there was really kind of worse forms of fixation, mostly K-wires and limited plating. Today with staples and headless compression screws, your union rates are much more favorable. You don't necessarily have to use iliac crest bone graft, but bone graft is advisable. And you want to consider using enough bone graft so that you don't have a ulnar impaction issue. If your lunate is fused to your radius, you can develop a secondary ulnar impaction. So you want to make sure you try to preserve the relative height of that lunate as well. So there are some good studies moving forward and recently that show favorable outcomes for these with, again, improving union rates. Benefits of the RSL fusion in that it does preserve that dart thrower motion. The functional range of motion is sort of questionable. I think most people and most studies would show about 50% of the normal side. You have certainly better non-union rates, again, with better fixation today. And even if you don't have a total fusion, and you have some of a fibrous non-union, it's not always painful, but you can develop mid-carpal arthritis secondarily from this over time. Distal scaphoid excision is advisable. Again, it seems to unlock the mid-carpal joint, and as far as range of motion, it's probably going to promote better radial deviation, but not so much flexion and extension. And there does seem to be a secondary benefit of improving the fusion rates with the distal scaphoid excision. So here's an example of a 40-year-old male who is enjoying and drinking a 40 on about 40 flight of stairs, who had this pretty significant articular distal radius fracture. And I thought I could treat it, just, fix it, bridge it, just try to put some pieces back together. But after taking that bridge plate out and realizing that I probably had pretty lousy fixation, he ended up with something like this, which is sort of a combination and a mess of an articular non-union and malunion in combination. So really, you're thinking fusion here, but you can't typically fuse something like this with so little bone stock, but you do have a nice vascularized piece of bone right next to your radius. So we ended up taking his distal ulna, perfused based on perforators off of that interosseous membrane and pronator, and then rotating it and fusing the rest of the carpus. And after about 11 months of praying and watching and waiting, he finally did fuse and heal with a fairly abundant bone. So my algorithmic approach to treating these malunions, I don't know if the highlights show up here or not, but if they're asymptomatic, I typically am considering an intra-articular osteotomy for younger patients. But again, it's sort of a discussion. If they're symptomatic and they're fairly acute, younger, minimal arthritic changes, then I'm considering an intra-articular osteotomy. And if there's progressive arthrosis, then I think you have to consider that partial versus total fusion. If there's radiocarpal arthritis, then, and they're older, I would try steroid injection. And when they don't get any relief, that's when I would consider denervation. And if that fails, then partial versus total fusion versus surveillance if they do get relief. So I'll end it there. I think hopefully that wasn't too much time, and hand it back to Peter.
Well, that was awesome. I think you went through really comprehensively all the different options for intra-articular malunions, not only including how to do the osteotomy, good tips and tricks, and then also for sure in those cases that with these intra-articular malunions that have gone into post-traumatic arthritis, what the salvage procedures are. So that was awesome. Thanks, Andrew.
Yeah.
Okay. Well, let's see. So we are at, 25 minutes, a little less than that. I'm going to go through some cases here. That was just, you guys just totally delivered. So thank you. I have quite a few, and so I'm going to just go through a couple here. All right. So this is kind of funny. It's weird because I say extra and intra-articular malunion. This is actually that one case I showed you, my patient from COVID who had this fracture here, and I had mentioned that this was largely it's the extra-articular malunion, the intra-articular fragment on CT. You can see there wasn't much the congruity here, the step up or down of the incongruity here was minimal enough that I didn't feel like I needed to treat that, and it had healed enough. I thought it was okay to leave, so I treated this like an extra-articular malunion. So Andrew and Joe, you both mentioned kind of how to treat these fractures in terms of closing wedge or opening wedge. Have you guys ever done closing wedge osteotomies or closing wedge osteotomies, which has the negative effect of you have to actually shorten the ulna too in most cases. Have you guys done that at all?
I have not, because I would be really concerned about making it super ulnar positive and having to deal with the ulna. I think the healing is much more predictable at the radius, particularly if you this one, for example, is pretty short, and you have the loss of inclination until just doing a nice osteotomy parallel to the joint line, distracting it, correcting your parameters, and then filling some bone graft in, to me is way more predictable than making a mess on the ulnar side.
Yeah,
I think bone loves healing and compression, but I think the risk of that change in variance is pretty substantial. And I agree with Joe. I mean, I don't do much with closing wedge. It's mostly opening wedge for me.
Yeah, it's interesting. It's would you rather have two bones love healing by compression, or one bone just needs to be bridged out in an area that's richly vascular in most cases. So I agree. And then, so I hear but it's worth mentioning because many people do go with a closing wedge and then concomitantly shorten the ulna, and they do heal okay. There's just always that risk of that watershed zone on the ulna that may not heal, but it's whatever you're comfortable with in your hands. Joe, you went through, you described how to do the corrective osteotomy. I just thought I'd go through just a couple of pearls that you actually already mentioned, but just have these videos here that kind of just show. I think one thing is whenever I see, one of our trainees that has a trouble getting the reduction, I typically notice that the exposure is not big enough or long enough, and it's typically at the most distal end. So I really open the FCR sheath volar and dorsal quite all the way down to the distal wrist crease, and then that allows me to mobilize it out of the way, and then really allows me to retract all the way beyond the volar rim. And you definitely need that exposure for most of these, especially if they're shorter fractures. And then certainly, Joe, you mentioned the BR tenotomy. I don't even. I think I just automatically, systematically always take this down if I'm going to do a corrective osteotomy of the distal radius. And feel free, guys, if you want to chip in with any of your own pearls. I don't typically like to put the plate on distally for acute fractures, but this is one that I do like to use the strength of the plate, which is anatomically pre-contoured and fits most cases. The only trouble with this is it takes a little bit of experience to put this plate to know, because you're going to really do, in most cases, a biplanar correction in the sagittal and coronal plane. You just have to pin this plate on or place it initially just to know that it's actually sitting correctly. And that requires you to have treated enough to know, I think that looks about right. So I pin it, and then realizing this is off out of the incision, looks a little wonky. But as long as I trust that this is in a decent spot, then it usually works out just fine. But there's still, I don't go all in at this point. I'll just show you what I do. I put this plate on, and if I like it, then I'll go ahead and just put 2 of the distal row screws in. I haven't really committed to it yet. I think if I really, really find that it's off, then I haven't burned too much real estate. So I'll just put those 2 screws in. And then once I've done that, I will do the technique that was described by, well, at least described really well by Fernandez on making your osteotomy parallel to the distal articular surface. So I'll first put a pin in that parallels the radial joint, and then I'll put another pin in right at the site of non or malunion, if you can identify that. I don't know if I can go back. Yeah. So here you can see a clear area where there's the apex volar angulation from this dorsal bending mechanism. Put that pin in there, and then another pin that's just perpendicular to the distal radius, just so I know. So here's that reference pin that's perpendicular to the long axis of the radius. Here's that radial carpal parallel pin, and here I can see clearly where that malunion site is in this established malunion. And then do you guys do a separate, if you're going from all volar, do you guys do a dorsal approach and do your osteotomy from volar dorsal, or do you just go all volar?
I'm all volar.
All volar. I definitely like to pronate that shaft out to be able to strip off the dorsal stuff, like all the scarring to tendons as part, in addition to the BR release. But I could pretty much, get it all volar. I'm ultra careful when I get down to that dorsal cortex from the volar approach, and really pay particular attention to get Homans around there to really protect everything. But I stick volar.
Yeah, release all
yeah.
that tissue around there. I agree, Joe.
Yeah, absolutely. I think that's key. And I feel I have not been burned on this yet, but I feel like from volar, I think the reason why people go dorsal is A, they're afraid they're going to cut the extensor tendons with their osteotomy, and then B, they have difficulty getting that the soft tissues and that really thickened periosteum released enough. And so I think I can do that from volar pretty well. So here I just really pull all the extensor tendons off. I get this elevator all the way back. And then I'll even put a little retractor there as we do the osteotomy. And then I can just kind of go almost all the way through and then kind of crack it open. But you guys made a really, really good point. It's that dorsal periosteum callus. I definitely, like here in this video, I pronate that proximal, that shaft fragment out completely. I almost actually not, just watching this, I realize when I do this, I'm like gritting my teeth, like, oh gosh, this seems wrong. But you definitely need that. Otherwise, you're not going to get your length, tilt, and height out of your distal radius fragment. So I'll do all that, and I'll even, as you can see here, once I can see everything, I'll actually get a ronger and just chip away anything else that may be stuck there. I don't know if I get to that here. Yeah, there we go. So I took that part out, but I just make sure it's fully free. Otherwise, you're just wasting effort. That's gonna be ineffective. And then bone graft. Do you guys? So Joe, you mentioned that if you have this any type of critical bone defect, you're gonna use some sort of autograft bone. I think you said iliac crest and proximal tibia. Is there ever a chance that you use like allograft or bone substitute at any time?
So I'd use it for the intra-articular, basically die punches. 'Cause I feel like there you don't rely so much on the healing from the graft itself. That's just a scaffold. I haven't honestly done taking care of many of these. Like if I do a hinged opening wedge osteotomy in a kid, I don't really graft at all. And I think throwing in some allograft in there would be kind of just, it would make me feel better if I
Yeah,
did a lot of them. But if I do an adult, I would probably just go to proximal tibia. I think it's a really good, you access it's very superficial. Like you get a bunch of good graft. It makes me feel better if I had to do it. I have one coming up this Friday. I did a Mascale style. He had a huge defect. I mean, I don't feel good about putting cancel allograft into a big defect and hoping it's going to heal. So I'm just going to go to his proximal tibia.
got it.
I
How
think
about
for
you,
me
Andrew?
too, Peter. Yeah, I think for me the big question is, do I have volar cortical contact when I do this? If I do, I've done it without bone graft, and I'm fine. I feel pretty comfortable. If I feel like I don't have good volar cortical contact, and I'm really trying to also distract the radius, like I absolutely will use autograft. But for me, I'll use some cancellous chips if I'm gonna feel good about myself and just stuff that defect. But it's really first and foremost, do I have that volar cortical contact after I get the plate and everything set?
Got it. Yeah, and I think that I think what both of you say, I think is very valid. There's a couple of schools of thought. Excuse me. Um, yeah, the volar cortical contact. It's debatable if if there is contact, if you need any bone graft, and if you need structural bone graft or non-structural would be fine. And really, the literature can support any of those things. And so, I think it's whatever is good in your hands. And Andrew, you said that if there is no volar cortical contact, you would use some sort of autograft. Does it have to be structural, or you just want the biology there? Even non-structural is
Yeah.
okay.
I think it depends on the patient. So if patient is, diabetic, alcoholic, which I feel like these are sometimes the malunions I'm getting, then I'm worrying about some of the biology. If there is no volar cortical contact, I would actually, and I have to get length on the radius too. I would actually consider putting in, structural autograft, and actually even consider putting in through a dorsal incision if I felt like I really wanted to get that graft fixated where I want. But again, I feel like I don't typically need to do anything like that as long as I have that volar cortical contact.
Yeah, yeah, and that's the approach that I take too. So we'll see how this one plays out. And actually, you reminded me for your presentation. Did you say 40s? Or a 40-year-old with that drank a
It was
40 fell down
40
40?
40,
stairs.
40-year-old with a 40 on about 40 steps. That
Yeah.
was the
Oh my gosh.
that's how I
Okay.
remember that.
That sounds more reasonable. Otherwise, is like alcohol dehydrogenase is like mutant.
Yeah. Yes.
Okay. All right. So at this point, in this patient, you can see that I elected to do non-structural allograft bone. I have good volar cortical contact, so that was my rationale for that. I always use a bone clamp. So at this point, I had put my plate on distally, put the 2 screws in, smooth screws. I didn't burn much real estate, but then once I put that plate back on and I do this reduction maneuver, and you could do it to just the 2 screws or put some pins in there or put all the screws in there. Just depends on how much you trust the bone and the fixation to actually hog on it if you need to and get this bone clamp to reduce it to the shaft. But if you like it, then you can put in the rest of the distal row screws. And you just need 4 screws in the distal fragment. And in the extra articular, you can do you don't have to necessarily do all distal row. You don't have to do all proximal row. It can be a mix. Just 4 is kind of the recommended amount of fixation in the distal fragment. So here, I was really happy with this. I put the allograft non-structural, just bone chips essentially. So I liked it. It looked good. And she oh, you know what? What else was there? Yes. So before I get to that, another comment I want to make is that when you have these kind of big corrections, you may have these spikes of bone that are prominent. I think Dr. Gill had mentioned the complications of extensor tendon rupture, and and this certainly in an area where there's like the EPL or whatnot. If there's rough areas, especially in EPL where there's a tight a compartment, may be prone to some type of attritional rupture. So if it's sizable, I don't have a good number. But if I look at it, I'm like, ooh, I don't really like that. Then I'll just, through my same volar approach, I can usually just get a ronger and just trim this down. Talked about bone graft. So I put this bone graft with some demineralized bone matrix purely just to make myself feel good, kind of throw everything at it. Another thing I wanted to mention is like in this patient here, a lot of patients that have nascent malunions. And, I think that, you sometimes in your schedule, it may not fit that you're going to treat it before it becomes an established malunion. And so you may have this fracture that is comes to you delayed or whatnot. They've been immobilized and they're stiff. I know that Paco Del Pinal had described arthroscopic releases, and I know the Duke group has talked about this type of extrinsic radiocarpal ligament releases. And I read those studies, and I certainly don't have the skill set to do it arthroscopically, but in this patient, she was super stiff. And so having done this for a lot of different patient pathologies that I treat, doing this very conscientiously, the volar and the long radial lunate, preserving the RSC, I was able to get pretty good motion, so I can get her a little jump up on her rehab afterwards. But then you have to trust your fixation to let them move and not be casted the entire time. But this I did on her, and I think it helped quite a bit. So here she was at, I think the 3-month mark. Yeah, so this immediate post-op, sorry. And then 3 months later, it looks like it's filling in, and she's kind of minimally symptomatic. Can't quite tell if it's from a impending non-union or is just she's still healing her osteotomy. But we watched it for a little bit, and then after a while, I really didn't see anything filling in, consolidating here, and I got a CT scan. And this is kind of a problem because I don't normally get a CT scan in these patients. Non-smoker, healthy individual, and because she was having some pain, and I had a CT scan. I think this was maybe at about 6 months, where I couldn't see like really any radial densities here that would consist with bone, but I saw stuff, some sort of radial density, not, I guess, iso intense to bone. We decided to go ahead and revise this. And so here at this point, I just put a iliac crest wedge of bone that I kind of whittled apart, and I left all that volar fixation the way it is and just put this kind of buttress plate to hold it in there. And then at 3 months, she was clearly healed. So I don't know. We're all very anecdotal, right? You have that one patient and you say, well, now even with volar cortical contact, I'm not going to use, non-biologic bone graft, but I still do. This hasn't really changed me too much. I don't know exactly if I left things alone, maybe she would have healed. There was no signs of impending hardware failure. Would you guys have just left it at 6 months, kind of minimally symptomatic, kind of, like a little bit of aches here, but it was really more me being concerned that it wasn't healing. And I just said better to just treat it now with a small dorsal approach versus having now her coming back in a couple of months with like hardware completely ripped out. What would you guys have done?
Yeah, I think certainly delayed union. I don't know when I would pull the trigger. I agree with what you did ultimately. When I consider a bone stem, but I think that has limited utility. Um, I showed that one guy, I did that vascularized ulna transfer on, and 3 months and 6 months, I was like, man, he's not healing. Am I going to go in and have to like bone graft him? And I just gave him more time. And, well, it took 11 months and he finally healed. So, I don't know. I don't know when things are technically non-union. Certainly, I think the last thing you want is for hardware to fail. That just makes things so much more complicated. So I'd rather do what you did and just prophylactically, treat an impending problem that could be catastrophic. So,
Yeah, I agree. Same, but I think that CT scan showing kind of nothing, like emptiness. Yeah, I would feel that, I would just, especially just complaining. So I would just basically say, well, let's just, by just doing the surgery, you're gonna by default shut her down again. You know what I mean, for a period of time. So adding some fresh autograft in there and kind of restarting things a little bit. I think I'd be leaning towards that as well.
Yeah.
did you have her activity modified up until that point at all? Or were you letting her do full range and weight bear?
No, I had her actually, I told her to completely weight bear because I wanted to see
Got it,
how
yeah.
stable it was and actually try to have her um like signs of like halo effect or things to tell me, oh yeah, I should go ahead and revise this. But when she came back looking like there's no movement, I'm like, oh, let me just get a CT scan just to confirm it looks okay because on planar radiographs you can't really quite tell. And I saw the CT scan, I'm like, oh. So then I was kind of forced to but yeah, I think, and she did great. So when I went back in, though, I didn't have any pictures here. I should have put some in. But at first, I was like, "Oh gosh, this is healed." But then once I localized it, there was definitely like, like it wasn't mush, but it was definitely like easily, scoopable with like your rongeur or your curette. And so I felt better intraoperatively that this was the right decision. Who knows if I hadn't gotten a CT scan and convinced myself that I should, then maybe she would have healed with time. Okay, so we have about 10 minutes. I had way too many cases here that, as you guys know, I kind of drag these things on. Um, I'm going to stop sharing here. Sorry, guys. I'm just going to find maybe one more case that maybe drives home a couple of different concepts here. Okay, actually, maybe I'll just do this final one. Bear with me here. Okay. All right. Can you guys see
Yep.
this full screen? Okay,
Yes.
perfect. So, excuse me. So this is the patient who had this distal race fracture, and she's hemiplegic on this side. She can still move her fingers. It's just not. She has good volitional control, but it's not. I mean, she definitely has some spasticity here. But her surgeon who evaluated her and treated her said, you know what? This is the injury picture actually, and they said you don't really use this hand, right? So we're just going to treat it non-op. And it was true. She didn't use it as much as her other arm, this was her non-dominant hand, luckily. But it was treated this way, kind of benign neglect, if you will. And then she came to me at about 3 months or so. I can't quite remember, 2 to 3 months afterwards, and she had incredible pain, and that was her chief complaint. She didn't mind the deformity that she had, but it was the pain. And so I got the CT scan because I knew that this was a very unstable volar shear type of fracture that was treated non-operatively. I got the CT scan just to see um, should I salvage this or should I go ahead and try to reconstruct this? And if I'm going to reconstruct it, is it nascent or established to help me with any type of intra-articular osteotomy is a little challenging. And so I got the CT scan, and based on this CT scan, what would you guys have done? Like there's, on that top right sagittal reformat, there's kind of edge loading, but it's on the dorsal half of the lunate. It's a very sizable volar rim fragment. Would you guys have that said, like some sort of like RSL fusion, but that also is challenging because your foundation is already cattywampus a little bit, or would you try to correct this and preserve her some motion here? What'd you guys do?
think no matter if you're going to salvage this or not, you almost have to perform some type of osteotomy in order to do whatever you want to do. And I couldn't tell from your formatting here the sequences if that's healed or if it's still kind of non-union-esque. Um, if it's not, I mean, to me, it's the same thing. I would break whatever nascent malunion or fibrous non-union there is. And in my mind, I'm just looking at this and I'm saying, I think this is in my mind, it's going to require potentially an approach from both sides, at least fixation, both sides, bridge plate, if you're going to try to salvage or just, restore some alignment and volar osteotomy and really try to restore the height and the length of that carpus in the appropriate position. But I think you have to address that those fracture fragments and potentially osteotomize again, even just to fuse it. If you wanted to fuse it, you still wouldn't be able to do it unless you got it in the right position and alignment.
Yeah,
Yeah.
exactly. Joe?
Agree totally. I think, how old is she again?
I think she was like 50, like mid 50s.
Yeah, I think, but I would probably offer both options. I would say total wrist arthrodesis with the PRC and somebody who has spasticity, somebody that's going to, because that's the issue I'd be worried about. You do an osteotomy, bone is kind of like osteopenic here, like we'll be able to hold, with the forces trying to kind of, redisplace it in that plane. Versus, so I tell her that's the risk. Like you fix it, you go through all that, and then it ends up failing, and you end up doing total wrist arthrodesis. So but if if she was okay accepting that risk, I think it's a reasonable option to try to correct the malunion. But if she wanted a more definitive pain reducing option, I think a PRC with the total wrist arthrodesis would be probably a little bit more kind of predictable long term. This is from my standpoint.
Got it. Yeah, I think I thought exactly like you guys. I didn't want to, just because of the hemiplegia, I didn't want to jump straight to saying I was going to do some sort of PRC or total wrist fusion, or I primarily was for pain, and I did believe that the pain was coming from this malunion and the articular incongruity. So I did that approach. I told them that. Um, that I could look inside the joint, see if it's salvageable in terms of the articular surface. But if I recall, I just chose to just go volar and just fix it and just commit to reconstructing it, realizing that if she has any post-traumatic arthritis that becomes symptomatic, then I would treat it. Keeping in mind that this is her hemiplegic side. And I think that, Andrew, you asked, you don't know quite what the sequence is here, if it's established or not. I think that this is likely a nascent malunion, and I think that was helpful because in the established intra-articular malunions, I usually will open the joint and then see exactly where my step-offs are, and then put some K-wires in. It requires a really extensile dorsal approach to hyperflex the wrist. And then I'll put the K wires in, and then I'll, just create my osteotomy combination of intra-articular, extra-articular to meet together. But in this nascent malunion, it's nice because I knew then I could likely just utilize this plane here, get a osteotome, and just kind of slowly, carefully just follow that weak area, and that should hopefully mobilize me and get me to the right area. This actually is also a good illustration as a little tangent. If you take care of patients that have, subacute fractures, often you'll go do your volar approach, and if you don't recognize that there's this callus right here, which is hard to see, it's not ossified yet, but it looks like it's bone, then you may not see this plane here, and certainly your pre-contoured volar plate may not fit. So these are like the subacute 2, 3, 4 week fractures, and so realizing that, the first thing I do for these scenarios is just to go to what I know is normal volar cortex, and I just chip away, and you just do it cautiously, and you'll know kind of tactile sense what's mature cortical bone versus this immature callus, and then that helped me then get this osteotome in here and do my osteotomy. So here I did that. So I found that plane. I did my osteotomy here. these volar rim, so now treating this like an acute fracture. So now I have this volar shear fracture. These are actually really hard to, especially if they go intra-articular like this, kind of in the mid portion of your A to P distance in the sagittal plane, coronal plane fracture. It's hard to maintain that, mainly because you may get it in the right spot and you get an image and you like it, but then when you put your volar plate on, what happens is it settles back down. That's why it's so inherently unstable. And then you kind of lost your intra-articular reduction. And so a lot of times for these, I'll just put my plate on and don't go across the fracture and kind of just pitchfork that fragment. And then I'll actually put that oblong screw hole in or use that to then elevate, make sure I like that, and I'll drive these pins across. And then once I do that, then I can reconstruct or just put the rest of the fixation in. So here is that patient at 3 months. And, she had, enough function in her hand and her pain was relieved. So I think this was a good illustration of just creating a new fracture and then adding some pearls in for this kind of hard volar rim fracture that's hard to stabilize. Okay. Do you guys have any comments? Because otherwise it's 8:15 my time, so 9:15 your time, and we can wrap it up. Any other thoughts here?
The other thing you made me think of, Peter, was that when you have, especially the extra-articular malunions, when you're putting those plates on and correcting and trying to get that volar cortical overlap, sometimes you got to rongeur that callus in order to get that plate to sit. So right at that hinge point, sometimes it gets like very lumpy and bumpy, doesn't fit. So when you're talking about trying to find the callus in that case, it reminded me that sometimes you got to rongeur that extra-articular malunion callus in order to get your hardware to sit right.
Yeah, that's exactly right. Exactly right. I think you don't realize that until you've been there and you're like, why is my plate not fitting, or where exactly is this plane? So I think that's a good point.
And one last thing with the technique you're talking about with the lobster, especially when it's the 40-year-old guy with the 40/40s, whatever Andrew is saying, you got to be cautious. I mean, you're really, really squeezing that lobster down and get that plate down. I think you got to be reassessing whether you cleared out enough callus and whether you release enough soft tissues, because otherwise those screws will just rip out of that metaphyseal bone.
Totally, especially if there's some disuse osteopenia. I always just kind of hold my breath when I do that. And it's like click, 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 like, oh gosh.
Oh God.
Otherwise, they're going right to Brown.
Yeah, exactly. I'm sending it to Philly.
Yeah, me too.
Yeah, exactly. I think to everyone listening, I think this is the beauty of hand surgery. I've known Dr. Gill and Dr. Miller for a while now, and it's just so fun to geek out on these things. And I learned so much from you guys tonight, and I'm very proud of you, proud to be your friend and colleague. So thank you very much for spending your East Coast time, which is quite late, with your young families with us tonight. Here are some upcoming courses that you can look forward to, these regional courses. So if these are in your area, you want to travel to them close by, just reach out to look at AO North America website for these opportunities. Here's a QR code you can scan. A couple of other webinars. These are incredibly helpful to me. So to the many people that are online right now, and then we'll watch later on recorded, here are the upcoming webinars that you can look forward to. Otherwise, that's it. Again, you will get an email in the next 24 hours, I believe, on how to get CME credits. But thank you so much, Dr. Gill, Dr. Miller, for your time. Love you guys. Thank you to our AO North America staff for supporting this and giving us all of this great AV support.